Good evening, everyone. Thanks for joining. My name is Tina Gregg. I'm a nurse practitioner at GI Associates in Mississippi. I've been here for 18 years treating liver disease. I'm part of the GHAPP MASLD MASH Community Network, and our goal is to help educate other healthcare providers and also the community on this growing epidemic of MASLD and MASH. So tonight, my presentation will be on non-invasive testing. And we will have a clinical case study for context throughout this presentation. So our patient's name tonight is Albert. He's a 65-year-old Hispanic male with a BMI of 29. And very commonly, he is being referred for elevated liver enzymes. He has abdominal ultrasound that's remarkable for increased echogenicity, which is consistent with hepatic steatosis. When we look at his lab values, his triglycerides and HDL, not too bad. A1C is 7.2, not perfect, but we'll certainly take that. His ALT has been elevated for about 3 years, 1 to 2 times the upper limit of normal, so below 100. He's had a workup and evaluation for other causes of chronic liver disease, including viral hepatitis, autoimmune hepatitis, and genetic causes is negative. He's had no alcohol at all in 45 or so years, so that rules out alcoholic liver disease. Medical history is pertinent for type 2 diabetes, hypertension, hyperlipidemia. These are components of metabolic syndrome that we typically see with MASLD. His physical exam does show some abdominal adiposity. There's no stigmata of advanced liver disease. And again, his BMI is 29, not obese, but he's heading in that direction. So taking all of this into consideration, we're able to diagnose Mr. Albert with metabolic dysfunction associated steatotic liver disease, which we also know as MASLD. Okay, so the next question that we ask after this diagnosis is, does Albert have any significant fibrosis from MASLD? And historically, we would use liver biopsy to make this determination. However, in more recent years, we have a plethora of non-invasive tests that we can use in order to assess these types of patients. So we have imaging biomarkers to assess the liver fat on the left and also the liver stiffness. So we can assess the liver fat with ultrasound quantitative techniques, MR spectrography, CAP scores, which is with FibroScan, MRI PDFF, and then when we're looking at liver stiffness, we have shear wave elastography, RFE, vibration-controlled transient elastography, or FibroScan, and the MR version of that, FibroScan, which is MR elastography. Over on the far right, we have serum tests that we can use to predict fibrosis, such as the FIB-4 score, the NAFLD fibrosis score. This was named before the nomenclature change a couple of years ago. We have the APRI. We also have proprietary serum markers for fibrosis, such as the PRO-C3, which we usually only see in research projects. We have ELF test, which is more commonly used these days, and we'll talk more about that. FibroSpect and Fibrometer. In the center, we have rules that combine both imaging biomarkers and serum tests to be able to make determinations. So we have the FAST score, the MEFib, and the MAST. So our focus tonight in further conversation will be on the ones that are in brown. All right, so let's start with the FIB-4 calculator. This is a starting point in most of the guidelines, and it's very accessible using patient information that we typically have on hand. And that includes the age, the AST, the ALT, and the platelet count. So we can plug this information into a calculator, and this can be Googled. We can find this online. A FIB-4 score of less than 1.3 generally has a high negative predictive value for excluding advanced fibrosis in individuals with at-risk MASLD. So on the other hand, we see a score 2.67 or higher, then this is concerning for advanced fibrosis. A score of 3.48, we start looking for other ways to determine if the patient may have cirrhosis. So another serum test, this is a send-off test. It's called the ELF test, Enhanced Liver Fibrosis Test. This combines 3 serum markers, hyaluronic acid, P3NP, and TIMP1, all of which reflect extracellular matrix remodeling and fibrogenesis, so basically collagen turnover. So rather than measuring liver enzymes that fluctuate with inflammation, we can use the ELF test to give us a direct look at the underlying fibrotic process. So on the left, you see the performance of ELF for detecting stage 2 or greater fibrosis. A cutoff point of 9 provides about an 85% sensitivity and 60% specificity. So that means it's quite good for ruling out significant fibrosis if your ELF is below 9. So advanced liver disease is unlikely. There may be some false positives that occur above that level, but for the most part, it's a pretty good test to use. And on the right, we see the same concept applied to stage 3 or greater fibrosis. So in practice, ELF is probably most useful as a part of a tiered approach. So combining it with other clinical factors or other non-invasive tests like FIB-4 or FibroScan to help us triage these patients. Now we'll look at some imaging tests that are able to help us make determinations and assess patients for fibrosis. These include transient elastography, so that's the FibroScan, MR elastography, so MR-based FibroScan, similar information, point shear wave elastography, and 2D shear wave elastography. Both of those tests use regular ultrasound technology to make a determination. So keep in mind that stiffness is the ability of an object to resist deformation in response to an applied force. Shear waves travel faster through a stiff liver, so those numbers will be higher the more fibrosis the patient has. So the liver stiffness increases with fibrosis stage. We'll talk a little bit more about this technology, vibration-controlled transient elastography. This is known as FibroScan. This is a very common method that is used that we'll hear probably a lot about in coming time. There are also similar technologies to FibroScan, but this is certainly the one that's been available the longest and the most used currently. So FibroScan is known as transient elastography. It's a non-invasive ultrasound-based test used to measure both liver stiffness and fat content in the liver. So you get 2 different pieces of information at the same time with FibroScan. It's considered a point-of-care test. Results are immediate. It can be done at bedside. So it takes about 10 minutes to do this test. So the FibroScan device uses a mechanical pulse, so a little gentle vibration, and ultrasound to assess how stiff the liver is. Small probe is placed over the skin, over the liver, and the probe generates a low-frequency vibration that produces a shear wave that travels through the liver tissue. So when we talk about measuring stiffness, the ultrasound transducer in that same probe simultaneously tracks how fast these shear waves move. Stiffer liver tissue allows shear waves to travel faster, while softer, healthy tissue allows shear waves to travel slower. So the speed of the wave is then converted into liver stiffness measurement expressed in kPa, so kilopascals. Higher values suggest increasing degrees of fibrosis. And then similarly, FibroScan can use a feature called controlled attenuation parameter, so a CAP score. This measures how much the ultrasound signal is attenuated as it passes through the liver. The more fat in the liver, the greater the attenuation, the higher the score. So with FibroScan, again, we get two pieces of information, the fat content in the liver, and then also the stiffness score, which is a surrogate for fibrosis. There are some considerations when we're looking at these reports that we need to take into consideration. Are there 10 valid measurements? There has to be at least 10 to have a valid exam. Is the IQR median less than 30%? It certainly needs to be. What is the image quality? We want the shear waves to be parallel, similar to in this diagram on the right. They don't always look this nice, but that's a very, very nice exam. We also ask ourselves, what was the success rate to obtain the 10 measurements? You know, did the operator have to get 50 measurements to obtain 10 quality measurements? Or were they able to obtain the 10 measurements in, I don't know, 12 to 15? That makes a difference. And then finally, is the operator experienced? We certainly want experienced operators. The more exams that they perform, the better your result is going to be. There are some limitations that we need to keep in mind when we're ordering these tests or interpreting these. So false elevations in your elastography score, so your liver stiffness score, can occur if the ALT or AST is elevated, usually higher than 100. If there's cholestasis, and then also if a patient has not been fasting for at least 3 hours. If the patient is actively using alcohol, so if they were drank, a 6-pack of beer the night before, then that score could be falsely elevated. If the patient is morbidly obese, BMI above 35, which we see very frequently in this clinic. If a patient has ascites or liver masses, your scores may not be accurate. The next test and the most reliable test, the most precise test of your non-invasive measures is the MR elastography. So this also uses shear wave technology. It utilizes an acoustic driver on the patient. So basically a large pad is placed over the liver, and it produces these really pretty colorful elastograms, which we see over here on the right. So the MR elastography is able to assess a much larger portion of the liver than the FibroScan. There are still considerations that we have to keep in mind, which include the BMI, iron overload, non-compatible implants, claustrophobia, which occurs fairly frequently, hepatic congestion. So does the patient have congestive heart failure or any hepatic congestion? And then also insurance issues. MR elastography is not as readily available as FibroScan. It is more precise, but it's also more expensive. So sometimes we have problems with insurance coverage with this one. And here's a little snapshot of some of the most common non-invasive biomarkers that we see used for advanced fibrosis to determine if that patient may have at-risk fibrosis. These include FIB4, ELF, vibration-controlled transient elastography, which is your FibroScan, and then your MR elastography. And this slide includes information for your rule out and rule in cutoff points, as well as limitations and strengths. So this isn't a comparison of the test. It basically just kind of outlines the different tests. So back to our case study, Mr. Albert, none of this information on this slide has changed. At the bottom, remember, we have the diagnosis of metabolic dysfunction associated steatotic liver disease. Our next step will be determining if Mr. Albert has any significant fibrosis. And the slide that I showed you previously with all of the information on the non-invasive test can look overwhelming because you ask yourself, okay, there's so many options, like where do I start? We now have guidelines and clinical care pathways that we can apply in order to help us work through these patient cases and algorithms. So the one on the right that we'll look at that I really like a lot because it's very simple, this is the one from the AGA. And it really starts with step 1, identify your patients at risk. Who's at risk for MASLD? Patients with 2 or more metabolic risk factors, type 2 diabetes, steatosis on any imaging modality, or elevated transferase, so elevated liver enzymes. And patients can have any of these. They do not have to have all of these, right? Mr. Albert does happen to have all of these, but that's not necessary. So step 2, history and lab tests. Does he use alcohol excessively? We look at his medical history as well. We determine if we have a CBC, liver function test, which we do on the right. So his ALT is 43, AST 38, platelet count is 170. So we decide we're going to calculate the FIB4, which is in the next step. His score is 2.22. So this falls in the indeterminate range in the center here. And we're going to have a large number of indeterminate ranges. And so when that occurs, what that tells us is that we need a second non-invasive test, right, to help us make that determination. So over on the left, FIB4 less than 1.3 is not concerning for advanced fibrosis, right? That patient should be pretty healthy and they can be reassessed in 2 to 3 years unless something changes to cause us concern that we need to evaluate them sooner. Okay, so Mr. Albert was in the indeterminate risk range. So that lets us know that we need a second non-invasive test. We decide to use liver stiffness measurement or FibroScan, and his FibroScan score, 6.7, puts him at low risk for advanced or concerning fibrosis. So with Mr. Albert, we can go and tell him to be well. We can ask him to follow a Mediterranean diet. We can ask him to control his other medical conditions, so his metabolic diseases. And then we can follow up and repeat his non-invasive test in 2 to 3 years. So Mr. Albert is healthy, but just to kind of a little bit more of explanation here, if that liver stiffness score is 8 or higher, they really need to be further evaluated and they need to be referred out to hepatology or gastroenterology that can focus on taking care of patients with liver disease. That is the end of the presentation on non-invasive tests. You can scan the QR code to complete a short survey and share your thoughts on today's presentation. Your insights help us understand what we can do to improve everything, and then also what you need in regards to learning. So we have some time for Q&A. If there are any questions, I'm here to answer them for you.